Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of. Well, I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Chad Rodgers. He's the Chief Medical Officer here at AFMC. Thanks for being here, Dr. Rodgers.
Thanks for having me.
So we're talking about ACEs. Tell us what that is.
Yes, so you hear people talking a lot more about ACEs. It stands for Adverse Childhood Experiences, which can include a lot of things, but most primarily you kind of think about experiences that children have usually in the first couple of years of life, typically between 0 to 5, but especially 0 to 3 being a big developmental time. So they're very intense or stressful experiences that happen to children at a very early age. They kind of had a huge impact on their development or their growth or their mental health. They kind of have persisted into adulthood. So we know from years of study about adverse childhood experiences and what causes them. There's the original CDC study, which you can look up online, the Adverse Childhood Experiences study, that people can learn that there's 10 that are kind of commonly talked about. And some of them are things like you traditionally think about, like abuse and trauma, or maybe homelessness and stuff like that. But there's a whole bucket of sort of household dysfunction of things that happen to people that sometimes you don't realize were not normal, but they really are kind of normalized in our culture. Things like a parent having a drug use problem, maybe having a parent that's incarcerated. So those are seeing someone in your family treated violently. They kind of have an impact on you at a very early age. Again, they were very intense, that you kind of felt were threatening. They kind of impacted your overall kind of trajectory through life. And so there's the 10 that are described, but there's really hundreds that you could. So it's really sort of some event that you kind of perceived it yourself to be at great danger, where you felt threatened either maybe physically or emotionally or spiritually, or whether it was like a nutrition thing, that you kind of carry on. And we know that people the more adverse childhood experiences you have, the more likely you are to have difficulty with your physical health, but also your mental health. So it can really have long-term consequences. And we just kind of continually get more information and more research is being done about the impact of these. And they're not uncommon. So a lot of us have experienced something that sort of kind of shaped us, whether it's for the good or the bad. But we now know the research of why that happens and why that happens within the brain and within the body with stress hormones and things like that. So people are beginning to talk about those things a lot more. And as a result of talking about them and knowing about them, we're also researching about how they happen and then how we can prevent them. So that's really kind of the whole encompassing idea around knowing and learning and addressing adverse childhood experiences.
And they are critical in identifying them in pediatric care.
Right. So it's a very good time to identify them when kids are early on. There's some things that we just can't prevent. I mean, we've all lived life. We know sometimes, bad things happen. But by identifying them very early on, we may be able to make some interventions early on that maybe help a family kind of prevent maybe making it worse, or maybe addressing it specifically to kind of help the child. The other thing is that we know that resilience is really important. So kind of looking at people's strengths and what are the things that kind of give them hope and joy for the future. And we can kind of help also bring those in, because those are the things that kind of help protect people. And we know that those adult child kind of healthy protective relationships are the kind of fundamental thing that protects children from the impact of adverse childhood experiences. So that's also kind of something that we can begin to address early on. If we can identify who are your resilience factors, what are the positive experiences that you're having at home and in the school and your community, so that we can help kind of prevent the effects of adverse childhood experiences.
And what should pediatricians and family doctors be looking for when screening? Is that something that happens during routine visits?
Right. So it depends on the practice that you go to. And so people will have every practice is probably a little bit different about how they look for them. I think number one, being aware of them kind of helps you kind of shape, because sometimes you have something going on with the family that you just can't quite figure it out. And it's like, oh, they're dealing with homelessness. Or they're dealing with the fact that the dad is incarcerated and the mother has some mental health issues. So knowing that the impact of those, there's not there are some screening tools for children, but most of the studies that have been done with screening have been done with adults. But again, I think it depends on your practice style and how you want to address them. They tend to be very personal, so sometimes they're very hard questions to ask. And there are also maybe questions that people are afraid to ask because they don't have a solution to. But I think just having the awareness about, the impact of ACEs, and also knowing about what the sort of the percentage of ACEs are in your community. So if you know that a lot of people experience poverty, then you know that there's a lot of families that are dealing with adverse childhood experiences. So there's lots of opportunity to screen, but you sometimes it's hard to do something that you don't know about. So that's where screen. And there's other ways to screen, like maternal depression or social determinants of health. A lot of things that we kind of talked about before that kind of give you some idea and some insight to how that's impacting their lives.
And how would a physician even approach that screening?
Right. So I think at times it takes a time, because I think it takes time for people to kind of trust you and be able to tell you things. Like if you walked into my office and I was like asked you a very interpersonal question, it could feel sort of violating and aggressive and may actually re-traumatize you. So I think it's something that kind of happens in a very trusted relationship, either whether that's with your primary care provider or your mental health provider. And over time, these things kind of come out. So it doesn't really even need to be a one-time event. You may learn things about people over time, especially as they feel safe with you and are able to share with you.
And what screening tools do you recommend for assessing ACEs in pediatric populations? Is there a specific tool that everyone should use?
There's some good standardized tools. I think Pearls is the one that I'm using most commonly. It's for young children and for teens. These are all screeners that are available online. The original ACEs screener is actually used in adults and not in children, so there's some things that you don't want to use, but someone shouldn't use a screening tool unless they've really had some training and evaluation, know the validity of that screening tool, and also to be prepared for the responses to those tools. So there's a lot of things that are available. Sometimes just a general good social history of talking to someone about divorce in the family or mental health issues of other family members are good ways to kind of elicit those adverse childhood experiences. But also other screening tools also look for elements of adverse childhood experiences, and they sort of add up when you begin screening or looking or asking people.
And what does it mean to practice trauma-informed care in a pediatric or even a primary care setting?
So trauma-informed care is, again, being aware, realizing the impact of adverse childhood experiences, knowing their prevalence in your community and sort of how they impact families, and kind of tailoring your approach to knowing how to respond to someone who has had. So making your place a very welcoming place, making it a place where people feel safe, making it a place where there's not a lot of barriers to kind of routine procedures within the office. So it gets down to really kind of the basic operations of the office as well. How people make appointments, how people are followed up, that they're not left out hanging in the cold without any follow-up about referrals or medications. So those are all things that to kind of think about around and making your practice kind of a more trauma-informed practice so you don't re-traumatize people. But I think the big element is you really create that safe space for people. And
does ACEs awareness extend beyond the clinic? Is this something that goes into schools, communities?
Mm-hmm. So anyone who works with children, especially people who have traditionally worked with children for long periods of times, have known that there's, the impact of trauma on children. But I think, anybody who kind of directly works with children in some sort of service, whether that's school or social services or like a after school program, needs to be aware of adverse childhood experiences, how it's impacting children. I think a lot of times you're like, where the question, when it kind of goes off in your mind, is like, what's wrong with this child? And it's the times you need to be thinking, oh, what happened to this child? What are the things that this child has experienced? And so by having that awareness, and again, also appreciating the fact that trusted relationship with adults, that we have a role as adults to create those kind of protective relationships with children to help guide them through those stressful situations. So it's, also kind of having that awareness.
Are there community-based interventions or partnerships that have proven especially effective? Right.
So there are several therapies and modalities that are going to use. Again, it's kind of tailored to the patient, but patient-child interactive PCIT therapy. It's something that people are well trained on. It's a great thing for, it takes kind of an adult and the child, so the child's care provider, to kind of do these therapies that kind of help kind of with emotional regulation and kind of identifying trauma and triggers. But there's other like cognitive behavior therapies, another thing that's commonly used. But you'll see a lot of different modalities. There's things that are kind of well accepted and and safe. I think, UAMS and our best have a lot of good resources for providing resources to providers who are well trained in the area of trauma, and they're doing things that are sort of generally accepted as being evidence-based and having good outcomes.
And what are some innovative approaches? Or is there promising research developments that you've seen recently?
Yeah, so there's just there's this ever-growing kind of body of knowledge. Again, we're able to do it down to the really kind of good research to kind of see the impact of the imaging on the brain and stuff like that. But I think the one thing is, really training and working with adults to realize how they interact with children is very important, and that they create that protective relationship. And I think that's, sort of the thing that we see, helping children learn how to emotionally regulate, which is really a skill that's kind of hard to come at, because sometimes when a child is kind of escalated and upset, then you find yourself being escalated, upset, and that really doesn't kind of help bring the child down. Recognizing that all behaviors have a meaning, so even bad behavior is sort of an adaptive behavior. So recognizing that's, and I hate to even use the word bad, because the child's just responding to their environment the way that they've learned or know how, but teaching children what are safe ways, what are good ways to kind of respond to stress. So there's a lot of good research, a lot of good tools that are becoming more and more available to people who work with kids in order to address these things.
And before we go, what should the healthcare community, if they want to learn more resources, training, where do they go? Yeah,
I think the CDC has really had a really good, lot of resources that people have gone to and used. I think there's a lot of local resources that you get into. AFMC houses a lot of resources on our website about adverse childhood experiences that they get to go to. There's also numerous conferences, not just nationally, but also locally. We're getting ready for our Adverse Childhood Experiences Summit coming up in a couple weeks. So it's sort of that annual visit to kind of look at some different areas of what's going on with adverse childhood experiences, because it is really a rapidly changing field.
Well, Dr. Rodgers, thank you so much for talking about this important information. And to find out more about the ACEs conference, they can check out our website.
Yeah, they can go to afmc.org. Just go in, or even if you just Google adverse childhood experiences, and AFMC should come up as the summit, but it's there on our webpage.
Thank you so much for being here today.
Yeah.
And that's it for AFMC TV. Have a great day, and thanks for watching.